for having me present on this topic. I'm coming to you from Los Angeles in California, where it's very early, but I'm happy to be here, and sorry we can't be together in person, but hopefully next time. I'm going to be addressing the issue of surgical therapies for severe emphysema and COPD. Just a couple of disclosures to make. Before we start, I was involved in 2 studies on minimally invasive interventions for lung volume reduction in the past, involving coil lung volume reduction as well as drug-coated stents. This is a quick outline of what I'm going to be discussing today. I want to spend most of the time on lung volume reduction since the topic of lung transplantation has already been addressed, but I'll touch on a few things there as well, and then close out with some future developments that look promising. So, as we all know, emphysema is a big problem. It's among the leading causes of death worldwide. And it's very expensive to take care of these patients, which creates a tremendous burden on our healthcare systems. Prognosis is variable, but can be severe for patients with advanced disease associated with air trapping and hyperinflation, which leads to impaired ventilation, gas exchange abnormalities, and respiratory muscle dysfunction. So physiologically, this happens as lung parenchyma is destroyed, resulting in reduced elastic recoil. This results in decreased alveolar driving pressure, decreased elastic airway support, and airway obstruction. That airway obstruction then leads to hyperinflation, and the hyperinflation leads to respiratory muscle dysfunction, impaired gas exchange, and even RV dysfunction, which can be a big problem in patients with advanced disease. And this hyperinflation is a key driver of symptoms and mortality. This is data which is now a little bit old, from 2005, but demonstrates that hyperinflation as measured by IC to TLC ratio is clearly associated with worse survival in emphysema. And it's also associated with worse quality of life. And by that, meaning a higher baseline dyspnea, significant exercise intolerance, decreased daily activity, weight loss, and reduced cardiac function through RV dysfunction in particular. So in terms of the patient journey, what happens to these patients as their hyperinflation progresses and they become more and more short of breath, they become less active. This reduced exercise capacity increases to less activity, more breathlessness, decreased activity. It becomes a vicious cycle with further deconditioning and frailty, which ultimately contributes to higher mortality in emphysema. Now, we have a number of different treatment options, some more and some less invasive. So you've heard a lot about these from medical therapies, such as inhaled bronchodilators, corticosteroids, supplemental oxygen. Pulmonary rehab, in which I'm a big believer, has a huge impact in not only the quality of life, but also survival in these patients. And when disease progresses, in spite of all that, and patients become more and more symptomatic, then we have the more invasive surgical options that we're going to be addressing today, including lung volume reduction surgery and lung transplantation. So talking first about lung volume reduction surgery, this is something that's been around for many years. It was first proposed as a surgical treatment for emphysema back in 1959. When Brannigan reported on 16 patients with emphysema who underwent surgical lung volume reduction at the University of Maryland, but also reported relatively high perioperative mortality associated with the procedure. So the first attempts weren't received with a great deal of enthusiasm, but subsequent to that, there were a number of different attempts made. You might remember the thoracoscopic CO2 laser approach, which had some early benefit, but no durable effect. And eventually, in the mid-1990s, Joel Cooper at Washington University in St. Louis resurrected the procedure when he reported on 20 patients who had surgical lung volume reduction with quote-unquote excellent outcomes. and then subsequently a report on the thoracoscopic approach doing the same thing. So these reports, in particular Joe Cooper's report in 1995, resurrected the procedure as a potential treatment option for emphysema. There was a great deal of enthusiasm about this. There were subsequent reports demonstrating improvement in lung function, including improvements in total lung capacity, FRC, residual volume, improved airflow as measured by spirometry, improved gas exchange, and improved functional capacity. And these were all relatively small, single center reports. And there were some reports demonstrating, physiologic basis for this improvement associated with decreased hyperinflation, improved elastic recoil as measured through maximum static recoil pressure to TLC ratio, for example, improved airway conductance, respiratory muscle function, and RV function. So, with all these information coming out on surgical lung volume reduction, more and more patients were frequently referred for this intervention, including at my center, where one of our surgeons was very much a promoter of this intervention. And it became as a miracle cure for emphysema. More and more patients wanted this because there is so much emphysema out there. A lot of patients are very symptomatic, and their quality of life is poor, and they really wanted to do something about their emphysema, as they do today. Now, because of this large increase in the demand for this procedure and billing that was submitted to CMS, which manages Medicare system in the United States, CMS sponsored or created a National Emphysema Treatment Trial Group and sponsored this study, which was subsequently published in 2003. This is the NET study that I'm sure you're all familiar with, but it's such a pivotal trial that it's worth discussing in a little more detail. This was conducted over 5 years. It's a randomized trial comparing LVRS to medical therapy for severe emphysema. And as I mentioned, it's federally sponsored, which is rare for CMS to sponsor these trials. But it was such an important trial to conduct that I think they invested in doing this. The primary questions that were asked were, what's the morbidity and mortality of the procedure? How often does the benefit occur? Is it durable? And are there predictors of benefit? The primary endpoints were 2-year mortality and exercise capacity at 2 years. Secondary endpoints included 6-minute walk distance, pulmonary function, quality of life, and degree of dyspnea. The study population was diverse and large. There were 17 centers involved. Over 1,200 patients were randomized. All underwent pulmonary rehab prior to randomization. And both median sternotomy and thoracoscopy were surgical approaches that were permitted to be used. Goal resection was about 20 to 30% of each lung, so it was a bilateral procedure. And medically treated patients were followed very closely and monitored for adherence to regular phone calls and clinic visits so that they didn't fall through the cracks. One of the concerns was that the surgical patients would receive more attention, more aggressive care, and therefore that might explain any differences that we might see. But the medical patients actually received, better than standard of care, I think, in this trial. These are the baseline patient characteristics of the study population, and it's worth mentioning at least that there were more men than women in the medical therapy group. And although there was a fairly heterogeneous group of emphysema patients, most of these patients had predominantly heterogeneous disease and predominantly upper lobe disease, which will have some impact on the results, as you'll see later. So this is a summary of the preliminary or the primary findings from the study. And there were several important things. Mortality at 90 days appeared to be higher amongst the surgical patients than amongst the medical patients. And there was no difference between centers and no difference between the surgical approach, whether it was median sternotomy or thoracoscopy. But at 2 years, the mortality was similar between the medical and the surgical groups, so that they came back together over time. With respect to secondary endpoints, the patients in the surgical group did better overall. And the subgroup analysis here turned out to be very important because it was these subgroup analyses that really taught us a lot about lung volume reduction. In particular, we learned that there was a significant high-risk group that had a significant increase in mortality. And this group was defined by patients who had an FEV1 of less than 20% predicted, the LCO less than 20% predicted, and a homogeneous pattern of emphysema on CT scan. The mortality, as you can see in this group, was so much higher that they were excluded after 3 years into the trial because of this higher mortality. And we also learned that the lower risk groups either did better or had similar outcomes to the patients in the medical therapy. So there's no difference in overall mortality between the surgical and medical groups in these lower risk patients. Although again, the secondary endpoints favor the surgical group. Baseline factors associated with difference in mortality were the distribution of emphysema and exercise capacity. And this lower risk group was characterized by upper lobe disease predominantly and lower exercise capacity. Those are the patients that tended to do the best. There was no baseline factor associated with improvement in quality of life. Baseline factors associated with difference in maximal workload was the distribution of emphysema. So in conclusion, from this very large, well-done study, is that the overall mortality with surgical LVRS and medical therapy was similar, but there was a short-term increase in morbidity and mortality amongst this high-risk group of patients that we really should avoid doing lung volume reduction surgery on, the ones that have non-upper lobe predominant disease with very low FEV1 and DLCOs and homogeneous disease. The greatest benefit was seen in patients with upper lobe heterogeneous emphysema who had a low exercise capacity measured by CPET with achieving less than 40 watts of activity. But there was evidence of limited durability. So there was a benefit, but it didn't last for very long. And this schematic is a good summary of what we learned from this trial. Primarily that the patients that benefit the most are those with heterogeneous upper lobe disease and low exercise capacity, and that we should avoid the surgery in that high risk group, of course. Now, this killed a lot of enthusiasm about lung volume reduction surgery. And we're not doing nearly as much of it now as we did before the NET trial was completed or shortly thereafter. So people started looking for alternatives to surgical lung volume reduction. And that's where these less invasive or minimally invasive approaches started to come in. And there were several, from bronchial valves to channels, stents, coils, and even chemical lung volume reduction involving a sclerosing foam. But the one that's been studied the most, and the one that I'm going to spend most of my time on, is the endobronchial valve approach. So now we have medical therapy, which is the least invasive, and pulmonary rehab, and the surgical therapies, lung volume reduction surgery, transplant on the far right. But now in the middle, we have these minimally invasive bronchoscopic lung volume reduction approach, which I'm going to show you is pretty effective, in my opinion, and in that of most of others. So the endobronchial valve system, basically, the concept is an introduction of one-way bronchial valves into the airway of a target lobe in one of the two lungs. So this is a unilateral procedure as opposed to lung volume reduction surgery. This is done in just one lung, one side. And I'll explain why that is in a little bit. The aim is to occlude and collapse a hyperinflated lung region. And it's been tested in both heterogeneous and homogeneous disease, but mostly in heterogeneous. The primary predictors of benefit are the ability to achieve complete occlusion of the targeted lobe and absence of collateral ventilation from one lobe to another across incomplete fissures. There are some potential adverse events, primarily pneumothorax, but also infection, hemoptysis from airway irritation, and valve migration, which occurs rarely. This is an example of one of the valves. There are two available in the United States and in Europe, I believe. This is the Zephyr valve, which has been studied the most. You can see that during exhalation in panel A, the valve opens and allows air to escape from the lobe that it's been placed in. And during inhalation on panel B, the valve closes and prevents air from entering into that airway. And that's how the valve creates atelectasis in the target lobe. This is a picture of the aspiration valve made by Olympus. It looks like a little umbrella. So the technology is different, but it achieves the same thing. It allows air to escape from the target lobe, but not to enter into the lobe during inspiration. And the end result is a redirection of volume from the target lobe that's occluded down to the relatively normal, typically lower lung zones where the lung can function more effectively. But again, this is a unilateral procedure, not a bilateral procedure, as this diagram would suggest. We typically only do it on one side, not both. And radiographically, this is what we achieve. On the left-hand side is a patient who's gone through a bronchoscopic lung volume reduction with placement of Zephyr valves in the right upper lobe. You can see that the right lung is smaller than the left lung. We've achieved right upper lobe atelectasis, and in comparison to the preoperative chest X-ray on the right, you can see there's a pretty significant difference in lung volume on the right side, which is how the benefit is achieved from this intervention. So with implantation of the valves into the patient's airway, there's a number of trials now, 7 total randomized controlled trials that have shown improvement in health status as measured by Bodie index, for example, quality of life, reduced shortness of breath as measured by dyspnea scales, improved lung function. That's really the key to a successful BLVR procedure. Now, subsequent to the NET trial that we went through already, a number of randomized controlled trials have been published studying these valves, 7 total. 6 of the 7 have studied the Zephyr valve, only 1 studied the aspiration valve. And they've gone through an evolution over a period of about 10 years. The first 2 trials, the VENT and the Believer trial, studied patients with heterogeneous upper lobe emphysema, but didn't do a very good job of excluding or looking for collateral ventilation, which turns out to be an important part of evaluating these patients. The subsequent trials did that through a technology called Chartis, which is proprietary to the Zephyr valve that allows us to measure collateral ventilation when we do the procedure. And if we can detect that there's collateral ventilation, we actually don't put the valves in because we know that they're not going to work. So just going through some of these studies individually, the first 2, as I mentioned, were the VENT study and the Believer Hi-Fi study that looked at heterogeneous emphysema with the Zephyr valve. They did not look for collateral ventilation or to exclude it. There was modest, but in spite of that, there was modest improvement in lung function, exercise tolerance, and symptoms. But they also reported a risk of higher COPD exacerbations, pneumonia, and hemoptysis. So that was the baseline. Reason for optimism, but still some cautious optimism, I would say. Subsequently to those 2, the IMPACT trial was published, which looked at homogeneous emphysema. And this is the only study that specifically looked at homogeneous emphysema as a potential target for bronchoscopic lung volume reduction. This study was, again, a prospective randomized controlled study. The primary endpoint was improvement in FEV1, which improved by about 17% in the study group versus the sham surgery group. And also, for the first time, reported a significant increase or risk of procedure-related pneumothoraces of about 25%. So again, room for cautious optimism in this situation. And this is the data from that study in the intention to treat population. There was a significant improvement in FEV1, but a 44% adverse event rate, 25% incidence of pneumothorax, which was concerning. And this is the primary reason why we now only do this procedure in one lung, because we don't want to encounter bilateral pneumothoraces, which can be life-threatening. Now, subsequently, the biggest study looking at the valve procedure is the Liberate study, which was published in 2018. This was the largest and longest study, a multi-center, international randomized controlled study of 190 patients with severe heterogeneous predominantly upper lobe emphysema, who had no collateral ventilation as measured by the Chartis system that I mentioned earlier. It's the only study that has a 12-month follow-up. All the other studies had only 6 months of follow-up through the end of the study. And this involved 24 sites. The primary outcome was post-bronchodilator FEV1 improvement to 15% from baseline or greater at 12 months. And the secondary outcomes are listed there: absolute change in FEV1, 6-minute walk distance, and quality of life measure through the St. George's. This is the summary of the results data. The primary endpoint on the left, greater than 15% improvement in FEV1 was achieved in nearly half of the patients that were studied in the valve group compared to the control group. So that was a significant difference between the two groups at 12 months. And across all of the secondary endpoints, the patients who received the valves did better than those in the control group, all the way across all of the secondary endpoints. So this was a pivotal trial that really showed a significant improvement, not only in lung function, but also quality of life measures. In terms of safety, again, pneumothorax occurred in about 25% of the patients, as it had in previous studies. And there was a slightly higher incidence of acute COPD exacerbations early on, within the first 45 days after the procedure. But long-term, at 1 year, in the valve group, there were actually fewer COPD exacerbations, a lower incidence of pneumonia, and less incidence of respiratory failure. So it appeared to be pretty durable, the impact of the valves in these patients at 1 year, which was also reassuring. And subsequent to this trial is when, this valve procedure really took off, and where interest in it has really increased significantly. With respect to pneumothorax now, I think it's important to mention that the vast majority of these pneumothoraces occur very early on, within the first 5 days after the procedure is done. For this reason, we keep patients in the hospital for at least 4 to 5 days after the procedure to observe for this problem. This is often a problem for our case managers who want to get these patients out of the hospital quickly after a procedure like this. But because of the pneumothorax rate, we have to be able to respond to that. We have to keep them in the hospital for 4 to 5 days. And this is, again, the reason why we only do a unilateral procedure, not a bilateral procedure. Although it could be staged over time. You could do one lung, 1 day, and then 3 or 6 months later, if the patient's benefit is waning, consider doing the other side. The REACH trial is the only trial that has studied the spiration valve that I showed you earlier. That's made by Olympus, that makes the same Olympus bronchoscopes that we use in our bronch labs. This was a randomized controlled trial assessing safety and effectiveness of the spiration valve system in severe heterogeneous emphysema. Again, a multi-center prospective randomized controlled trial versus standard of care in 99 patients. 2/3 of them randomized to the treatment arm and 1/3 to the control group. Primary endpoint was FEV1 from baseline at 3 months. So not as long a trial as the Liberate trial, but the benefits were very similar, and the outcomes are very similar using either of these two valves. So they can really be used interchangeably, in my opinion. Although there's more data on the Zephyr valve, arguably. This is a quick summary of these studies that have looked at the valves. Again, Liberate is the largest and the longest trial that most of us really hang our hats on. The other trials are smaller and 6-month trials, but they all consistently show the same thing: about a 15 to 30% improvement in FEV1, a significant improvement in exercise capacity and quality of life. So the summary of the data really supports the use of these valves in severe emphysema. And more recently, there's data from a single center in Holland with 15 years of follow-up that demonstrates an improvement in survival. And this is new. This is just published this year, which was welcome news, that we may actually be improving the long-term outcome in terms of survival in these patients by treating them with lung volume reduction with this minimally invasive approach. What about comparing bronchoscopic lung volume reduction to surgical lung volume reduction? And there actually is one study that attempted to do this, published in 2018. This is called the CELEB trial. It was a comparative effectiveness lung volume reduction surgery trial for emphysema versus bronchoscopic lung volume reduction with valve placement. It was a 12-month trial, multi-centered versus a control group. The primary outcome here was the Bodhi index, which has prognostic value in emphysema. And secondary outcomes included the CAT score, residual volume, quality of life measures, and even the free fat mass index as a measure of BMI. And there was similar improvement in Bodhi index, residual volume, and similar safety when you compare BLVR to surgical lung volume reduction, which is also reassuring that they both seem to achieve the same thing. The minimally invasive approach certainly associated with less perioperative morbidity. And if any of you have taken care of these patients who have gone through surgical lung volume reduction, you know how difficult it is to care for them postoperatively. They have 100% incidence of pneumothorax by definition, and they can have chest tubes in place for days, if not for weeks, waiting for these air leaks to resolve. So I think most physicians and certainly most patients would opt to a minimally invasive bronchoscopic approach, especially now that we know that they're similar in terms of outcomes. Now, what about some alternatives to the valves? And there are a few that have been studied, including the use of coils. There are 2 randomized trials that looked at this. I was involved in one of these. They do seem to improve exercise capacity and quality of life, but they have not been FDA approved in the US because there just isn't enough data. The drug-coated stents create channels between the alveoli and the central airways. There's one randomized trial looking at the efficacy of these, which showed no sustained benefit. And with respect to sealants, sclerosing sealants, there is the AirSeal trial. It's the only trial looking at these, but it was randomized, and it did show improved volume, lung volume, spirometry, and functional capacity and quality of life. But more data is really necessary for the use of these sclerosing agents, which may turn out to be a good alternative to the valves. So now switching gears over to lung transplantation. I know that this topic has been covered already, so I'm not going to spend as much time on it. But I just want to cover hopefully some of the things that may have not have been discussed and fill in some of the gaps. Lung transplantation is something that has been available for treating advanced lung disease now since the mid-'80s and really took off in the early 1990s. Emphysema and COPD in general has been one of the most common indications for lung transplantation. And this is data from the International Society for Heart and Lung Transplantation demonstrating this. But this has changed over the past several decades with the advent of new lung allocation systems, including the lung allocation score system in the United States, which gives priority to patients with interstitial lung disease because they have a worse prognosis. So we've seen the shift in North America in particular towards lungs allocated more towards ILD patients and less so to emphysema, but the emphysema group still accounts for the second largest group of patients that is receiving lung transplants. Candidate selection is sometimes complicated, but there is a statement published by the International Society for Heart and Lung Transplantation in 2015, which basically recommends lung transplantation for patients who are clinically and physiologically severe disease, who have failed medical therapy, or for whom medical therapy simply isn't available. They should have a limited life expectancy of about 2 to 3 years because the outcomes with lung transplantation are limited. But at the same time, patients should be ambulatory and have good rehab potential. They should not be bedbound because they generally do not do well. They should have good nutritional status and have a satisfactory psychosocial profile so that they can follow the postoperative care plan adequately. And because it's an expensive proposition, they also need to have adequate insurance to cover the cost of this therapy. For emphysema in particular, we want to refer patients who have clinical deterioration despite maximal medical therapy, including pulmonary rehab, and who are not candidates for lung volume reduction surgery, BLVR, or who have gone through that therapy and failed to improve or had only a limited benefit. The Bodhi score is very helpful in prognosticating, so we typically do use that to help us decide when to list a patient and when to transplant them. If they've had episodes of hypercapnic respiratory failure, they have a poor prognosis, and certainly FEV1s that are very low, less than 20 to 25%, are generally good candidates for transplant, all else being equal. Now, lung allocation, as I mentioned, changed in the United States in 2005 from a system that prioritized patients based on seniority on the wait list to this lung allocation system, which prioritizes patients based on risk of death on the wait list and likelihood of benefit after survival based on a previous cohort. So each candidate is assigned a lung allocation score between 0 and 100 when they're listed. And then organs are allocated to the higher scores first within a 250-mile radius, although that's also changing now this year with what's called a continuous allocation system to try and allocate lungs to patients, irrespective of where they're located, who have more advanced disease and improve outcomes. The result of this has been that waitlist mortality has been reduced significantly. There are fewer patients on the wait list because they don't need to accrue time anymore. More transplants are being done, and transplants have been shifted to sicker patients, which is why the mortality risk has decreased significantly in these patients. So it has had a significant positive impact. And some centers in Europe have adopted similar symptoms. In spite of that, we still have a significant shortage of lungs to go around for the patients that need them. We still have a significant, about 6% mortality rate on the transplant wait list. So we're always looking for ways to expand the donor pool, including using marginal or extended criteria lungs that aren't perfect, and the use of DCD lungs or lungs from donors that have achieved death after circulatory death, meaning they're not brain dead. And there are studies now that demonstrate that the outcomes with DCD lungs is just as good as with standard lungs from brain dead donors. So we're looking for these all the time. In terms of bridging the transplant, this is not something that we did very often prior to the COVID pandemic, but subsequent to COVID-19, we had a lot of young patients in the ICU on ECMO and on ventilators who did not recover and had no other option. So we really started looking at the option of transplanting these patients. And we learned a lot from this experience over the past 3 years. Primarily that patients do better if they are on VV ECMO as opposed to VA ECMO, so that they have good, healthy circulatory system that can tolerate the surgical intervention. It's better if patients are able to ambulate on ECMO than if they are bedbound. We know that from previous experience. And better outcomes in high volume centers who are transplanting very young patients. So this is not for the elderly emphysema patient over 65 years of age. This is really for the younger patient under 40 years of age who may have cystic fibrosis, some form of ILD, or, as recently a post-COVID ARDS that just isn't recoverable. So very limited. In terms of complications, there are a number of different pitfalls with lung transplantation, from early postoperatively to intermediate within the first year, and even late complications that are listed here. I don't want to go over these all in detail because you've heard about these already. Primary graft dysfunction is the biggest concern early on, immediately post-op. It tends to occur within 72 hours after the surgery, and it presents as ARDS, with bilateral infiltrates, hypoxemia. It can be graded from grade 0 to 3, depending on the PF ratio, with grade 3 having the worst prognosis. And the differential diagnosis is listed here. It's the common things that we tend to see postoperatively, including volume overload, aspiration pneumonitis, pneumonia. Rejection, typically not this early, but hyperacute rejection can occur early. Immunosuppression is important to make transplantation successful. It started preoperatively and continued post-op for life, including a combination of calcineurin inhibitors, antimetabolites, and steroids. Not all centers use induction therapy, but most do, and is helpful in preventing acute rejection. One of the things that's particular to emphysema patients is native lung hyperinflation if they receive a single lung allograft, as in this case, where you can see the right lung was transplanted and the left lung hyperinflated. This can occur early or late and can have significant impact on morbidity and mortality. There are a number of things we can do about it, depending on when we see it. But one of the things that we can do now is place the bronchial valves that I showed you earlier for emphysema treatment to do a bronchoscopic lung volume reduction on the native side. And that actually does work quite well. And we've done it several times successfully in our emphysema single lung recipients. In terms of outcomes, emphysema patients do just about as well as other patients early on, within the first 5 years. But after that, their outcomes are not as good as for other patients. They tend to be an older patient population, and especially if they receive a single lung allograft, they are at risk for complications within that single lung allograft, including primary lung malignancies. So bilateral is probably preferable to single lung transplantation, even in emphysema. But we're getting better at it over the decades. Our outcomes are better over recent years than they have been in the past. And we now tell patients that, at 5 years, it's no longer 50% survival, it's closer to 65, 70%, which is certainly a welcome improvement. Leading causes of death early on, infections, graft failure within the first year, but subsequent to that, the more common problems become chronic rejection, which is labeled here as BOSS or CLAD, chronic lung allograft dysfunction. Malignancies start becoming more common, and infections never really go away. It's always a risk factor because the patients are always on immunosuppression. CLAD, or chronic lung allograft dysfunction, is the biggest limitation to long-term survival. It's defined as a persistent drop in FEV1 from the postoperative best achieved FEV1. There are two major phenotypes, the most common being obstructive. Many risk factors for developing BOSS, and limited in terms of what we can do about it, short of enhancing immunosuppression, limiting other complications, treating with azithromycin, which is an immunomodulatory therapy, treating other factors that contribute to BOSS, such as reflux esophagitis, and ultimately retransplantation for appropriate candidates, which isn't an option for most, to be honest. BOSS occurs very frequently, and again, data from the ISHLT demonstrates that about 50% of our patients develop some evidence of chronic lung allograft dysfunction 5 years out from transplant. Even if they don't feel it, we can detect it on spirometry. With respect to future developments in lung transplantation that might help outcomes even further, researchers are looking into things like stem cell transplantation from donor-derived stem cells to inhibit immune cell function, at least early on, blunt ischemic reperfusion injury, and encourage clearance of pulmonary edema for PGD. Xenotransplantation has been in the news recently, and is still something that's being investigated, that has been investigated for many decades, using both porcine and primate sources primarily, but it's really limited by acute thrombosis and acute severe inflammation. So until we develop models with knockout xenoantigens, this is something that's probably not going to be available for most patients in the very near future, but certainly potentially in the medium-term future or the far future. Bioengineering is something that's very interesting, that's generated a lot of interest as well. This involves recellularizing an intact whole lung extracellular matrix with the patient's own stem cells, so that rejection wouldn't be a problem. Immune tolerance would be achieved, and we wouldn't have all the complications associated with immune suppression. But it's complicated. It involves recellularizing with 40 various different cell types. So it's something that's been studied in laboratory models and animal models, but hasn't achieved clinical applications just yet, but holds a lot of promise and something that I'm particularly interested in. Now, shifting gears to other minimally invasive therapies that hold some promise in the near future, targeted lung denervation is something that's recently been proposed. This involves bronchoscopic radiofrequency ablation therapy for COPD. This is done with a bronchoscope, like bronchoscopic lung volume reduction, using a probe that disrupts parasympathetic pulmonary nerves, the vagus nerve primarily, affecting the lung, and results in decreased airway resistance and mucus hypersecretion. There's one study called the Airflow 1 trial, published in 2019, which was a multi-center randomized controlled sham control trial that studied COPD patients with MMRCs greater than 2 and moderately to severe lung dysfunction, FEV1s of 30 to 60%. So not as bad as we would expect for lung volume reduction. And the primary endpoint in this trial was the rate of respiratory adverse events at 3 to 6 months, which was improved in the treatment group compared to the sham control group. But the benefits seemed to be lost at 12 months. The Airflow trial looked at patients with both severe and moderately severe emphysema, and the benefit was seen in both groups. So it's something that's minimally invasive and certainly may be beneficial in moderately to severe emphysema. At 3 years, there was an assessment of the same cohort looking at long-term impact and safety at 2 different energy levels, 29 and 32 watts were used. There was a concern about GI safety because we're targeting the vagus nerve. And it turns out that there were no significant GI adverse events in the treatment group compared to the control group. But that the effect on moderate to severe emphysema and lung function seemed to be stable at 3 years, which was welcome news as well. So this is something that's in development. It's not FDA approved in the United States just yet, but I think it's certainly something that might be available to our emphysema patients who may not be candidates for bronchoscopic or surgical lung volume reduction. And then finally, bronchial rheoplasty is hot off the press. This is a therapy that utilizes endobronchial catheter to apply non-thermal pulse electrical therapy to the airwaves. It is an ablation of the airway epithelium. Preclinical studies have demonstrated epithelial ablation followed by regeneration of normal epithelium. So it's a good therapy for chronic bronchitis, not just emphysema, improvement in symptoms there. There's pooled analysis from 2 studies, although they're small. Primary outcomes looking at CAT scores and quality of life at 6 to 12 months, with secondary outcomes including adverse events and airway histology. Both studies showing improvement in CAT scores, quality of life, with few adverse events and no deaths, fortunately. So in summary, as my time is up, lung volume reduction surgery can benefit patients with emphysema, but a relatively small group, as we learned from the NET trial. There is a good physiologic basis for improvement with lung volume reduction. As I mentioned, the NET trial was a very important pivotal trial that taught us that there is a small group of patients with upper lobe heterogeneous emphysema that can benefit from this intervention, but there are groups of patients we should avoid it in. There are multiple minimally invasive therapies that have been developed, primarily the valves have been studied the most, which definitely can have a benefit. But again, they're not for everybody. There are newer therapies on the horizon that certainly can be beneficial. And the lung transplantation really remains the only definitive cure. And with that, I will complete my comments. And if there are any questions from the audience, I'm happy to entertain them. Thank you.